Hey, good morning, everyone. Thanks so much. I'm Paul McLaughlin. I'm taking over as MC for this next panel, and it is my delight and pleasure to welcome Xavier Amatriain to our next presentation. I hope I got the name pronounced correctly. Fantastic. He is the CTO of Curai, and he'll be talking about AI for COVID-19 and online virtual care approach. And he will be presenting up until 11:10. Where we will have a quick break up until 11:40, and then we will resume. So thanks so much, and looking forward to the presentation.
Awesome. So can you all hear me and see my slides? Yes. I'm guessing that's a yes. Okay. So it's great to be back at MLconf. I'm an old-timer from MLconf, just like Josh. Have been attending and presenting at the conference for many years since I was at Netflix leading the machine learning team there. And I always say this is one of my favorite conferences. I've hired a lot of people out of meeting them in the conference. In fact, I was thinking that as of now, I'm interviewing at Curai, another person that I met years ago at MLconf. So I'm sad that we won't be meeting over coffee breaks and whatnot, but if you're interested in this kind of work, feel free to reach out to me. I'm happy to meet and talk to all of you. So I'm going to be talking about COVID-19 and AI and machine learning. So I'm going to be continuing with the topic of this session, which has been very interesting to hear so far. And for those of you that don't know about Curai, I'll start by telling you a little bit about what are we doing, who we are, and how does this fit into the general landscape of healthcare, and then to the current pandemic situation. And I'm really happy that we are having this thematic sort of like session on healthcare, because it's probably one of the few topics that can distract people from politics nowadays, right? So what is maybe as important or more important than politics is healthcare in this situation that we're living in the world right now. So a few things that I've mentioned even in my last year's talk at MLconf is this notion of like healthcare is really screwed up, right? There's a lot of things that are not working and are going to get worse unless we do something drastic and radical in changing healthcare. There's very little access to healthcare. There's an estimated more than 50% of the world with no access to essential healthcare services. 30%, I mean, that's not only the third world, 30% of US adults are underinsured. And then doctors are put in this very complicated situation where they get less than 15 minutes to do everything, to give you a diagnosis, to recommend treatment, and they're off to the next patient. And we've also made them sort of like use tools, technology that doesn't really help them, right? Because it's basically designed to do better billing and better tracking of money, but not really to help them practice better. And then, of course, because of that, it's not only that there's a lack of access to healthcare, there's also a lot of medical errors, and there's an estimated 400,000 deaths a year due to misdiagnosis, which is crazy to think about, right? But even when you compare to the deaths that COVID is causing, it's awful. And of course, in the middle of all of this, which was already happening, you get a pandemic. And of course, this just makes it worse, right? So there's a bunch of articles, some of which I have quoted here, about how COVID has exposed how bad healthcare is nowadays. And one of the interesting trends is because of this, and because people wanted to have immediate access to healthcare and answer their questions about the pandemic, a lot of people started looking towards telemedicine, right? It's like, hey, we have this thing here on the side that people have been trying for many years. Could this help? And the reality is that telemedicine kind of can help, but it's not enough, right? It's really new technology on the same workflows and the same kind of processes that we had in the past, and that's not enough. So what we're proposing at Curai and what we're working on is a pretty, radically different approach to healthcare. It's all focus on this idea of providing healthcare, the good, best quality healthcare to everyone in a very accessible, very affordable way. So it's mobile first, it's always on, it's accessible and affordable. Very importantly, you can only do that if you get to a level of automation that only AI and machine learning can provide. But that AI and machine learning is not here to replace human providers and doctors. It's just to augment and to scale them, right? And we talk about this notion of the always learning system and this feedback loop with data in the loop, that it helps sort of like the model and the system get better over time, and design AI to operate in the wild. I'll be getting into all these concepts, but this is kind of like a general notion of like how we integrate the AI in the whole system. So how does this look like in practice? Well, this is how it looks like. Unfortunately, right now, you can only use it if you're in California. We're going to be scaling to the rest of the country in the next few months, but we are only operating in California right now. But if you're in California, you can download the app and for your iPhone or Android and start using it right now. So on the client side, on the patient side, sorry, you see it's mostly a chat-based application with some added features, like you have your portal with your record for your visit and whatnot. On the provider side, on the doctor side, you actually get a lot of different integrated AI tools into a homegrown EHR. So we have designed bottom-up an EHR that integrates into these new workflows and into this new way of practicing medicine to avoid problems like the one Yin from NYU a couple talks ago was talking about how hard it is to integrate something into Epic. We didn't want to have that limitation, so we basically designed the EHR from the bottom up to be completely integrated into this AI first kind of like workflow. Okay, so that's a little bit of context about what we're doing, where we are. Let's talk about AI research and state-of-the-art AI for healthcare. And there's been a lot of advances recently and a lot of talk and publications around using AI for a lot of different things like radiology and image recognition and a lot of different things. We have been publishing also at Curai. Interestingly, this is the exact slide that I presented last year. And I'm not going to talk about any of these papers today because we have new things that I'm going to be talking about, particularly related to COVID and some other interesting new research. But if I have to say, like, what do we need in our case? What do we need to enable this end-to-end sort of like patient to doctor flow with AI and machine learning embedded in the middle? There's really three different areas that we're focusing on. One is medical reasoning and diagnosis. The other one is NLP, a lot of analysis of text to understand what the patient and the doctors are saying, to extract information, understand. And then a multimodal AI, for example, to recognize images for dermatology. We've done some work on that, and to integrate other modalities that are not only text into this conversation. A couple or three principles that we over time have kind of like converged that are really, really important in everything we do in our AI and machine learning work. One is this notion of extensible AI, right? We want models, AI that over time improves and that reacts to this feedback loop and this notion of ever learning healthcare system. We also are in a domain that is very knowledge intensive, like medicine. So we want to be able to inject knowledge as a prior and then update that knowledge with data. That's another very important principle. And the third one is this is a high stakes domain. We cannot make mistakes. And it's very important for the AI to understand when it doesn't know something and to enable, for example, to then say, hey, I'm going to escalate to a doctor because I don't really know what to do next. So all these three principles are in different ways connected to our research and the work that we're doing. I'm going to give you an example. This is a new example that I think it's pretty interesting and pretty cool. It's new. It's going to appear in the MLP 2020, and it's about building automatic summarization for medical dialogue. And I'm also going to be connecting it to GPT-3, which I think it's also a very hot topic right now, and particularly in healthcare. There's been some discussions with Jan LeCun talking about like how it's not useful in some contexts for healthcare. But I'm going to give you an example of how it can be useful. Okay, so what is the context here? What are we trying to summarize? So here is an example, right? We're trying to summarize medical conversations with doctor and patients talking. And actually, it's not only doctor and patient, it can be AI and patient and doctors all included. But there are dialogues, right? And they're very intensive on sort of like medicine, and there's a lot of medical concepts included. And we want to summarize that. In order to do it, we use this notion of local structure. So we automatically detect and extract snippets, summarize the snippets, and then build a summary out of the summaries of the snippets. That's the basic idea. Now, in order to do that, and that's all in the paper, which you can find on arXiv, we basically build an extension of the pointer generator network, which was published in 2017 by the Stanford NLP group. But we had to think about a few things that are different in the context of the medical domain. So one of them is we penalize the generation aspect in the loss function to incentivize the model to actually copy more. And in particular, to copy more when there are medical concepts. So we also modify the attention model so that it focuses more on medical concepts. And the other thing we had to do is really introduce this notion of negation. It's very important to get the negations and the positives right in a medical conversation. Not the same to say, I have a cough, than to say, I don't have a cough. Of course, it's very, very different, right? And then we also introduce new ways to evaluate through different metrics and doctor evaluation. So here's an example of the results. And on the left, you can see that this is a pointer generator network fine-tuned on our data. And this is the proposed model, which basically includes this notion of, again, penalizing the generation and more attention to the medical concepts and the negations. I mean, I'm not going to go through the example because we don't have time, but the very important thing here on the right, you see the evaluation by medical experts, by doctors, which all kind of like agree that the proposed model is much better than the fine-tuned baseline. And in fact, in over 60% of the cases of the summaries, the summary includes all the important concepts that the original text or the original dialogue included. Okay, so that's what it's going to be presented in EMNLP. The new thing, which is very new, and I'm just like giving you a teaser here because actually we're working on presenting, on publishing it probably in an upcoming publication, is we have now introduced GPT-3 in the mix. GPT-3 is not involved in generating the summaries. It's actually being used to supplement training data. So we use GPT-3 as a labeler. And interestingly, what we've seen, and this is kind of like mind-boggling, is that using GPT-3 as a labeler gets us to better results than using human. And when I say human here, it's actually doctors providing the labels. We do get, of course, better results if we combine them both, which is great, right? That's what we want to hear. But one of them surprises is that even using GPT-3 alone to produce labels, we are getting better summaries than using our doctors to provide the labels. So anyway, this is an example of an interesting sort of like human in the loop, very healthcare heavy, but also using state-of-the-art deep learning and language models and NLP to provide value in the context of our service. I'm going to focus now a little bit more on COVID-19 because that's, has been a big focus of many of the things everyone in healthcare, including ourselves, have been doing in the last, 10-minute warning, thanks, in the last year. So I will say that in the context of the model that I showed, this kind of end-to-end patient, doctor, AI in the loop, we have had sort of like special tools developed for the pandemic and for COVID-19. I'll be talking about some of them in the next few slides. One of them is we developed very quickly a personalized diagnostic assessment in which this was specifically sort of like tailored to answer the question, do I have COVID, right? This is not the question of like, what do I have? It's just, do I have COVID? And we introduce a lot of different sort of like information, like geospatial information, which Josh also mentioned, depending on the zip code that you wear, depending on a lot of your demographic and a lot of different things, what would your risk of having COVID? Very importantly, of course, because our model is having the provider in the loop, at any point, the provider, the doctor, could jump in and then connect you to actually the next steps, be it a test, or be it a final diagnosis, or be it a care plan, because you might not have COVID, you maybe have the flu, right? So all of that is integrated into end-to-end. Now, interestingly, in doing that, we also started getting positive and negative examples of COVID-19, right? We had some data that we started to generate out of these assessments. So what we did is we trained a COVID-19 aware model, which as far as I know, is the first ever, and I haven't heard anyone train a machine learning model from COVID, because you need to have data, right? And having data for that, it's not easy. So how did we do this? First of all, we use the same principles that we use in our prior work, which is this learning from the experts paper. The notion here, or the basic idea is you generate synthetic data from an expert system, which introduces the domain knowledge. And that's the baseline that you're using to train, and combined with other real world data, right? In the original paper, we actually used EHR data and train a machine learning model on the combination of the expert system, the expert synthetic data and the EHR data. And we proved and showed how the learned model was actually better than the original expert system. Anyway, so what we did now is, hey, we have COVID data. We can add that COVID data to the original synthetic data, and we train a machine learning model using similar deep learning approaches. And interestingly, I'm not going to go into details because I don't have time, but you can read the paper, it's online. Even in doing that, we already get in top 3 accuracy, better accuracy than the reported accuracy of the average doctors in this 2018 paper by Fraser and al. We use the same data set, the same evaluation data set. More importantly, even after introducing COVID as a disease, our model is still good on the previous diseases, because that's an important thing, right? You don't want to lose accuracy as you keep introducing data in what the model knew from before. This is an example, right? So before this, an input: female, middle age, fever, cough, nasal congestion. Before introducing COVID into the model, influenza, an infection of bacterial pneumonia, and COVID-19 in this case appears in second in the differential diagnosis. In this other case where we have healthcare worker, which by the way was an added finding, a symptom that we didn't have before, then COVID-19 comes up on top. Okay, last least, I see I have 5 minutes. I'm going to make it. So another example of a COVID-19 focused work that we did is matching user questions to COVID-19 FAQs. As I said before, one of the things that people really jumped onto doing very quickly after we all realized we were in a pandemic is to find information. And a lot of websites, a lot of places were adding FAQs and answers to questions, but it soon became very hard, right? That you had so many questions that had different answers, and answering the exact thing that the user was looking for was very hard. So we devised this system. Basically, on the what's under the hood, it's a double fine-tuned BERT model. We use pre-trained BERT, then we train it on a generic question answering task. Actually, I shouldn't say generic. It's a medical question answering data set. So we train it on the domain of medicine in the question answering task, which is not the one we're interested in. We're interested in question similarity, right? But then we fine tune it again on a question similarity task on data that is outside of domain. And again, in the paper, you can see all the details, but that's what generated the best sort of like medical question similarity, because one of the tricky things is you need data, right? And there's not a lot of data on question similarity for healthcare, but there's a lot of data on that, for example, from Quora, from the question duplication Kaggle competition that Quora had. And we use that as a sort of like second step. And then here's an example of like the user question is when did COVID symptoms start after exposure, which we match to how long is it between when a person is exposed to the virus and when they start showing symptoms. And we have several examples of that. The important thing is when we match it, in our case, right, when we match it to something that could be related to an emergency or to a medical need that you have right now, then you can click and start talking to, again, our providers or the combination of the providers and the AI that we have in the system. This is actually how it looks on the app, so you can try it yourself. And this is the product in action for the COVID-19 sort of FAQ section. Okay, so conclusions. I think, as I mentioned at the beginning, healthcare is pretty clear to everyone that needs to scale quickly, and in this global pandemic situation to become even more obvious. And we believe very strongly that the only way we can scale healthcare is we just don't have enough doctors, and we can't get more out of the doctors we have or produce more doctors. So we need to introduce technology and AI, but in a way that it integrates well with the human providers and the human patients, of course. And in order to do that, you cannot just drop it in the old workflows and processes and hope that it works. That's not going to happen. It needs to be integrated end to end, and workflows and processes need to change. And that's what we're trying to do at Curai. And if you're interested in this mission and this kind of work, feel free to reach out to us and to me, because we're actively hiring at many different positions. So thank you. That's all. I think I did it, made it on time, and maybe there's some time for questions.
So we have a couple of seconds left. Would be if anyone has any questions in the chat. I don't see any, but if anyone has any, oh, great. Here's a question. Can you tell us a bit more about how did you create the COVID-19 model? What data did you use, and did you scrape the medical literature?
Yeah, it's a great question, and I think I went a little bit too fast through these two slides. We did not scrape the medical literature. Now, very importantly, you need to introduce knowledge, right, into any model that deals with medicine, and that's why Carlos' question is very good. Like, hey, where does the knowledge come from? The knowledge in our case comes from the expert system, right? What is the expert system? So this expert system is a knowledge base of medical knowledge that has been created for almost 50 years. In fact, it's been developed by a very well-known medical institution, and we have exclusive access to sort of like this underlying knowledge base. This is our medical literature, right? It's actually more than medical literature because it's kind of like synthesized into a knowledge graph where you basically have relations between symptoms and conditions and diseases. So that's instead of sort of like parsing medical literature and extracting information, which is a very noisy process, we actually use the expert system, and we generate synthetic data from that expert system. Again, that's all explained in this paper. We generate data in a very methodical way, and introducing, for example, noise and variability into that data, because you need to do that in order for the model to be robust when you're training it. And then, so that's the base, right? That's your medical literature, so to speak. But then you have to add real world data, which is, again, the combination of data that you can get from electronic health records. And in particular for COVID, what we did is we got the results of our own COVID-19 assessment data. So basically, we do have a feedback loop here where we can keep training the model as we get more information and as we get updated information, because at that point, really, we had little information, and we were going with the little information that we had, and the information that was, again, being closed in the loop by our own patients and our own providers, sort of like giving us labels on the assessments that we had.
So thank you so much. I just wanted to cut in. So we actually, over time, but I wanted to let people know that we do not have a speaker coming up for the next 30 minutes. So if there were more questions, I think, and you're willing to take them, I think we can put them to Xavier. Or if you wanted to catch another panel for these next 30 minutes, please pop over to any of the other stages, but please do come back because we have some fantastic presentations coming up at 11:40, starting up again in our agenda. But I will pause here and see if there's any more questions that pop up in the chat.
Yeah, I'm hearing Carlos very happily saying that expert systems can be useful. Yes, Carlos. I mean, that's been one of our surprises too. But it's this combination, as I mentioned before, the combination of traditional old school AI like expert systems with deep learning is, I think it's very telling of like a domain like medicine where there's a lot of expertise and it's very knowledge intensive, but you can't stick to the knowledge you have, right? I think this is a very important lesson learned. It's like, if you have an expert system that has been designed, it doesn't matter for 50 years, but you have COVID now and you get new data, what do you do? I mean, you can redo all your expert system, right? You can reevaluate all the probabilities in the nodes that have been introduced by hand. And this gives you a path to sort of like making expert systems useful as a prior, where you're introducing the domain knowledge, but also to be flexible enough that you can actually add new data as it comes, right?
Absolutely, great point. So thank you so much. I don't see any other questions, so I will say going once, going twice. Thank you so much. So we do have a break now coming up until 11. Let me just double check that. Coming up until, yes, 11:40, when James Ashenhurst from 23andMe will be presenting. So thank you so much for joining us, and we will be right back.